All right, well, let's go ahead and get started with those we have here, and hopefully we'll get a couple more people participating. All right, so we're going to do our echo here, and our theme is going to be, it has to be my thyroid, because it always is the thyroid. I'm sure you hear this all the time. Probably one of the most common labs after BMPs and CBCs that are drawn on patients. So something that hopefully this talk will be helpful as you try to sort those labs out and know when to refer. Let's see. Click to make it go forward. There we go. I don't have any disclosures. I don't have any financial interests in the thyroid. If anyone knows of some, let me know. So we're going to go over a couple things. We're definitely going to spend some time on hypothyroidism, do some cases related to that, talk about congenital as well as acquired forms of hypothyroidism, some kind of other causes of low thyroid, and lab evaluation. Then we'll talk about hyperthyroidism and kind of do a case related to that. Folks have questions along the way, just unmute your microphone and chime in. And I'm also going to be asking you questions, so I do want it to be interactive. So kind of basically, hypothyroidism, the telltale sign is going to typically be a high TSH. Total T4 or free T4 could be low or sometimes normal. Total T4 as well as total T3 are affected by thyroid binding proteins, and you can have thyroid binding globulin deficiency in males, and that's about 1 in 4,000. So sometimes when we get newborn screens that use a total T4 or other method, we have to rule out TPG deficiency. And then your hyperthyroidism, you're typically going to have the low TSH due to inhibition from high free T4 and total T3 levels. In hypothyroidism, your two most helpful labs are going to be your TSH and your free T4. And then hyperthyroidism, the same labs, but the total T3 is actually going to be very, very helpful because the total T3 is going to become abnormal first, and it's also the first thing to get better with treatment. So total T3 is really good. People often order free T3s. They're really mostly junk. The reference ranges aren't good. Reproducibility of free T3s is not good. I just recommend not checking a free T3. Any questions about just general thyroid function tests? Okay. So obviously we have the newborn screen, and we are following the newborn screen program now for our region. Tennessee is a TSH first test, followed by potentially reflex free T4. If you have a positive newborn screen, you should send the serum TSH and free T4 to try to determine it. A lot of things come into play for the newborn screen. When was it taken? Was it day of life 1, day of life 3? Were they premature? Are there other contributing factors? So especially the kids in the NICU are going to get this screen multiple times, and often they get flagged in the beginning, but we find out as we move along they're false positive. This is just a nice chart. I hope it's showing up for you okay, but you can kind of see on this chart that there's a difference between the TSH spike that happens right after birth in a term versus this dotted line, which is the premature infants. You can see there is a notable spike in that first 24-hour period, and then it starts to slowly go away with people being with it trying to save money now and women often being discharged from the hospital faster, newborn screens are often collected within the first 24 hours of life, and that can sometimes throw off and create some false positives in terms of TSH elevation being thought as hypothyroidism. Then also you can see kind of the T4 levels in a term versus premature baby also are significantly different. We do use a variety of reference ranges and other things to try to determine based on age whether labs are abnormal, and sometimes we just end up having to repeat or follow because they're borderline. In terms of congenital hypothyroidism, it is the #1 most common thing on the newborn screen. Only about 30% of the world actually screens for congenital hypothyroidism. That's unfortunate, as many people are left untreated and end up looking like this infant on the slide. Most of it's from thyroid dysgenesis, so ectopic, aplasia, hypoplasia. 15% is going to be dyshormonogenesis, and you'll often find that going through a family in kind of an autorecessive-like pattern. And for whatever reason, we're seeing more cases. It's unclear whether we're just catching more mild cases or if we're now capturing cases that were previously missed. Because Tennessee is a TSH screen state, we do miss central hypothyroidism, which happens to about 1 in 50,000 infants. Other newborn screen programs use a free T4 first, followed by reflex TSH if free T4 is abnormal approach. And there's some advantages to that in terms of capturing those central hypothyroidism cases. And there are several states also in the country that perform 2 newborn screens. And those who perform a second newborn screen actually find about 15 to 18% of their cases on the second screen. Usually dosage is going to be 10 to 15 micrograms per kilo per day, but it is based to some degree on how TSH is elevated and the weight of the child. Things that would be tip-offs, obviously, to be concerned about congenital hypothyroidism: late delivery, 42-week gestation. You can get the large tongue, but that's usually only over time after not being treated. Umbilical hernia can be present at birth. Prolonged jaundice is one of the ones to watch for. In that upper right corner, you have the cutis marmorata that you can sometimes see. And then one thing that often people will find is that there's kind of a wider than normal open posterior fontanelle. And that can also be found in the anterior, as often kind of exaggerated in size and then tends to close slowly. So that's kind of congenital hypothyroidism. We do get the newborn screens and try to coordinate with you in terms of serum testing and starting treatment. We're always happy to talk with you about what next steps should be. Any questions on congenital hypothyroidism? All right, so we have Sarah. This is a very, very typical case. A lot of referrals come in this regard. So Sarah's 14. She's been gaining weight, about 20 pounds in the last 4 months. She's also had some fatigue, hair loss, some sweating. She's always hot. Family's absolutely sure it's the thyroid, 100% sure. The patient is above the 99th percentile with a BMI of 31, has some asthma, had a TNA, has some asthma-related medications that you can see there. One family member, great-grandmother, had the thyroid out, but we don't know why or what was going on. She doesn't have a goiter on exam or lymphadenopathy, but your exam of her neck is kind of limited because of obesity. You do get some labs, and the TSH is 6.4, which is above the reference range. It goes up to 5.8, and then you get a free T4 that's within normal limits. So the question is, what do we do? Should we start treatment? Should we refer, repeat, any other labs? What do people think? Anyone have an opinion? Someone gonna start treatment? If you have audio, it would be great for you to chime in. All right. We seem to have a very quiet group. If you have audio, I would love for you to chime in. I don't care if you even have the wrong answer. And a lot of times in this, there isn't necessarily an answer. Oh, do I hear someone?
Yeah. Sofa, we're gonna venture repeat in a few weeks.
Okay. Okay. So we have some folks that like to repeat a couple weeks to see if this is a real trend. That's very, very reasonable, especially since if there's any recent illness, that could affect our result. You know, one thing that is kind of important to remember with these TSH values is they are going to vary by lab. They're often an adult reference range, and they don't compensate for obesity. So there are several studies that show that both children and adults who are overweight tend to have an elevated TSH, usually in the 5 to 7 range. And typically, actually, if you check their TSH 10 times, you'd find about half of them are normal and half are in that somewhat elevated range, depending on the lab's reference range. So it creates a conundrum because according to literature, that's actually considered a normal reference range for an obese individual, and treatment is not recommended. However, once these labs come back, families often cling to them as being the ultimate answer for the child's obesity, and are absolutely assured that that's the cause. So that can be problematic. So other things that we might do in a kid like this is, we do have one family member with some form of thyroid disease that had to have their thyroid removed. So you could consider thyroid antibody testing in this patient, especially a teenage girl. Girls are going to have 16 times more likely to have Hashimoto's than boys. So that would be something to see if you actually have true antibodies. Certainly no goiter was found on exam, though that exam could have been limited by the fat tissue in the neck. Certainly repeating is a very reasonable thing to do in this case. It's a very mild elevation. I certainly wouldn't rush in with levothyroxine at this point. If someone's got a mildly elevated TSH and a lot of thyroid antibodies and is very symptomatic, we will consider treatment. It's not kind of automatic. Most opinion, if we've got a lot of endocrinologists in the room right now, you probably find that a lot of them won't treat unless it's at least 2 times the lab reference range. So for most people, that means most people don't treat unless the TSH is over 10. But there are a good group of physicians or pediatric endocrinologists that would treat a kid at a lower level if they had a goiter or thyroid antibodies or were very symptomatic and wanted to do a trial of treatment. Certainly we're always happy to refer, but usually in these kinds of cases we would suggest repeating and kind of following over time, because you may find that things aren't really shifting or changing, and you're often going to find a free T4 in the mid or upper range of normal. So this actually could be just a normal response to obesity, the body trying to upregulate the metabolic rate and use energy. So it could be really a natural adaptation to obesity. Any questions on this case? This is a very common case that you're going to run into over and over in general pediatrics. All right. Certainly, we're always happy to talk with you if we can. Sometimes the volume of calls exceeds what we can immediately respond, but we do try to get back to people. So here's our 11-year-old, and you can see his growth chart there on the left, and this is how the patient looks. Anything strike you as odd about this patient?
Well, the height and weight discrepancy.
Yeah, so we've got a significant discrepancy there. And then if I show you a little bit more information, here's even more information about how this child has gained weight and grown. And there at the top is also, with the arrow, is the expected midparental height for this child. So what strikes you about that graph?
Good question.
Yeah.
If you have time, can you discuss thyroid antibody abnormalities with normal TSH-T4? How often to recheck or what to do?
Sure. I'll discuss that in our Hashimoto section. But anyway, going back to our chart, anything strike you as not looking normal about this particular chart?
Well, his weight or his height looks like gone down by 3 deviations versus his weight staying the same pretty much.
Right. Yeah, so we've got someone who's clearly has consistent kind of weight gain, but now has crossed multiple percentile lines and is below the first percentile for height. Also, you can see he kind of has a bit of a coarse features, a broad forehead. So that, this person is someone who was born with hypothyroidism that was not treated. So we're not usually going to see that dramatic picture in the United States, although I have had one case of that in the United States from a family who was all natural and didn't have a newborn screen and had a home birth. That was very unfortunate. But symptoms that you should be looking for as someone usually gets an acquired form of hypothyroidism, it's just the growth is going to fall off, but their weight's going to be stable. You might notice a pubertal delay. Sometimes they'll look more puffy, especially around the eyes. They may get a goiter. Other symptoms which are more common in adults but can happen in kids is cold intolerance. Constipation is a hard one because so many kids have that, so it overlaps. Certainly dry skin or brittle hair. And then I get this report often is, you've got an A student that's suddenly becoming a C student in terms of school performance. Rarely you would get galactorrhea. That's be a very rare finding. You can often, if you have profound hypothyroidism, the cholesterol will be elevated. You get your lipid panel. And then other signs on exam, again, they'll be short. I would say in terms of people who are referred to me for short stature, some will come with no labs and we'll check their thyroid and find that there's an issue and we fix it and they start growing just fine. Certainly a goiter would be common. Once in a while you can see a bit of bradycardia. It's not usually super profound, and usually it's because you can see that the way their heart rates were before are not like they are now and can attribute it to something else like physical activity. And then of course you've got kind of those other features. The other one on physical exam, especially if someone's really got good hypothyroidism, is you're going to get a slow return of your reflexes. And basically it's kind of a slowed relaxation phase. So it'll come up, but then it will kind of come down slower than usual. So those are kind of things to look for. There's lots of things that cause acquired hypothyroidism. The most common thing you're going to deal with in pediatrics is Hashimoto's. We'll talk a little bit more about Hashimoto's. You can get infection, have subacute thyroiditis. There's various drugs, anticonvulsants, lithium, amiodarone that can cause issues. And then I've kind of listed some other possible causes there. One very rare form that we have only a couple people in our clinic is thyroid hormone resistance, which is kind of its own lecture altogether. So I'm not going to talk too much about that. But in terms of other kind of more rare things that we see with hypothyroidism, we've got the external radiation. They may have been treated with radioactive iodine, surgery, obviously, and then you kind of have some more rare cases there just for reference. I've seen the Langerhans cell histiocytosis do it. Okay, so usually you're going to get a free T4 that's low and a TSH that's normal if you've got like a central problem. And central hypothyroidism is kind of tricky to diagnose because sometimes you're just capturing someone in an illness and their TSH is either low or normal along that curve. And if you follow it, you'll find they're okay. Sometimes also you're trying to figure out, is the free T4 really low? You can send a free T4 by equilibrium dialysis, especially if there's the patient's on medications or other things that you think could be affecting the free T4. It's much more accurate, and it's a way to kind of see whether the free T4 is truly low in the spectrum of a low normal TSH. Then you have primary hypothyroidism, where the TSH is going to be elevated, and the free T4 could be normal or low. So one of the things people ask about is it, you could, let's say we get our thyroid labs, there's TSH is elevated, maybe it's 7. We know there's some thyroid antibodies, a little bit of TPO or a little bit of thyroglobulin antibody. So the question is, when do we treat? And sometimes you also, on a lot of kids with those antibody findings, you may also just get a normal TSH. And the answer is usually just having antibodies alone. If your thyroid level is otherwise normal, we would just continue to follow those before we would start treatment. The question people often ask is, well, could they benefit even if it's just a mild TSH elevation? And adult studies seem to suggest the answer is probably yes. There's studies that show better memory, attention, and that lack of treatment seems to be associated with lower mood and quality of life, and that lack of treatment also increases cardiovascular risk. So these kind of studies are lacking, though, in children. So if you do have an elevated TSH in the kind of 5 to 9 area, it's definitely an area of question. Certainly if you have a child less than 3 and they're symptomatic, especially if they had antibodies, you would treat. You want to normalize the TSH, such a critical time for brain development. We follow people very, very closely through the first 3 years. For others, it's really more of a watch and wait. Repeat the thyroid levels every 3 to 4 months, and even less often if they continue to come back normal. You can get the thyroid antibody testing. Again, often remains mildly elevated in obesity. So if you've got a TSH in that 5 to 7 range with obesity, and they're antibody negative, and there's really nothing else, there's usually no reason to treat those. And some of it's going to come down to a variety of factors, also kind of negotiating with the family a little bit. I will say that, I think families are kind of surprised when they think it's the thyroid for everything, which weight gain is what most people attribute to low thyroid. The honest truth is most kids don't gain much weight when they're low thyroid. In fact, most kids with TSHs greater than 150 have a normal curve in terms of their weight gain. So it's really more of an adult issue. Most findings hypothyroidism are usually more of an adult issue. So it's pretty rare that we actually find that obesity-related weight gain is related to the thyroid. But if you do want to start treatment, here's kind of some basic dose ranges. You can see that actually you give quite a bit more of levothyroxine when you're younger than when you're older per kilogram. And then you can see that we follow people very, very closely. In infancy, as often as monthly, up to 6 months, then every 2 months up to age 2, and then every 3 months from age 2 to 3. And after that, you really only need to follow someone usually about every 6 months. And then if you change the dose of the medication, it's good to follow up within 6 to 8 weeks. The reason for that is that thyroid hormone has a very, very long half-life, about 6 to 7 days. So, you know, it's going to take 5 half-lives for that thyroid hormone you're giving to your patient to actually reach therapeutic levels. So it's usually not helpful to get in older children anyway. There's really no utility in getting labs any sooner than that after you've started treatment. In younger children, sometimes we will kind of watch the trend in labs just to make sure that everything's trending in the right direction as they're starting treatment as an infant. Any questions about kind of Hashimoto's, treating, dosage? Okay, got a quiet group.
Oh, I have a question.
Yes.
Can you review where you want TSH and free T4 to be? And don't, like, especially if you have cognitive symptoms or depression, don't you want the T4 kind of running in the high end of the normal range?
That is a wonderful question. So the answer is there is no consensus. And that most endocrinology thyroid experts, of which one of my good friends is the one who wrote the textbook, wrote Up to Date, and so forth, his answer would be no. His answer would be that there's no proof that trying to keep the TSH lower and the free T4 in a higher range of normal improves outcomes for children. There's not good data that proves that that's true. The question is have we really even got good data? And then the second question is, well, what do you do with the family that feels like if their TSH is lower and the free T4 were higher, that they would feel better if they're still symptomatic? And with that, I try to be diplomatic. If I feel like, you know, the TSH is in the higher range of normal and there's a little room for the free T4 to come up, then I might try a higher dose and see how things go. But often as that TSH comes down and the free T4 is a little higher, it's typical that people will continue to complain of the same symptoms of fatigue or depression or whatever else they've associated with their thyroid. So I haven't noticed that has been a significant improvement for many patients. You know, like any placebo, if someone thinks it's going to work, it might actually work. Some people I think will report they feel better, but it's unclear to me that that's really the case. So I don't do a lot to try to drive down TSHs, you know, like less than 1 or something like that. I know some people do try to do that to get higher free T4 levels. On the flip side, there are some who argue that there are a subset of patients that do need those levels to feel normal. But again, data is kind of lacking to show that actually is the case. So I negotiate with families. I talk through them. I try not to be too, what's the word, paternalistic. I once in a while I'll compromise and we'll try a little higher dose to see if it makes a difference. That's kind of how I handle that. Any follow-up question on that, or?
No, thanks.
Okay, great, thank you. So just kind of looking at autoimmunity, you know, the two big players are going to be Hashimoto's and Graves'. Hashimoto is actually a Th1 predominant in induction of the FAST expression on thyroid cells. The thyroid cells will then apoptose, and you've got destruction, and you've got Hashimoto's. It's going to cause inflammation and typically some degree of goiter. Whereas Graves' disease is a Th2 predominance, humoral immunity. You're going to get a TSH receptor antibody that stimulates. You can also make a blocking antibody that causes the thyroid to become atrophic. Both are possible. And then you've got Graves there for the stimulating one. So antibodies that you're typically going to send, there's actually a number that you can send. The ones that really you're going to send in a primary care setting and that are really readily available commercially are going to be the thyroglobulin antibody and the thyroid peroxidase antibody. And then some of these other antibodies can be sent for Hashimoto's, but sometimes they're just not commercially available. There's less data on them. Usually it's going to be a pediatric endocrinologist that's trying to find a reason for a goiter that doesn't make sense that might send those additional antibodies. But sometimes we have problems with insurance coverage. So this is kind of an interesting study. Back in 2006, there were 160 children with Hashimoto's. They had ultrasound findings that were very typical for Hashimoto's, usually a little hypervascular, and kind of show signs of increased size. And then you've got often positive TPO and thyroglobulin antibodies. And interestingly enough, of those 160 children, they found that 105 of them fell into having Turner's, celiac, diabetes, or Down syndrome. So those are high-risk groups and people to follow. So if you have people in your practice who have any of those, you should be kind of watchful for autoimmune thyroid disease. Certainly if they have a family history of Hashimoto's, that should be a tip-off as well. Hashimoto's, type 1, and celiac are kind of the triangle of autoimmunity. And of course, for our type 1s, we're always screening them for Hashimoto's and celiac on an annual basis. In fact, I had several patients recently with type 1 develop Hashimoto's disease. So if you have those kinds of people in your practice, do watch for it. I do see a lot of children with Down syndrome, and I'd say about half of them who have true thyroid disease have autoimmune thyroid disease, and that can be either Hashimoto's or Graves'. So, any questions about these high-risk groups? So this is just a slide that kind of, you can kind of see, this is kind of trying to show you what happens when someone is sick and might have some acute thyroiditis, which can be painful. But often they can just have these kind of labs occur without necessarily any pain, but having been sick. You can see here is in the blue is the serum TSH. Initially, as an illness starts, it might actually be decreased. We think that's maybe the body trying to preserve energy and metabolic kind of power as the illness starts. And then during that period, serum T4 here in the red will often be increased. And we think that's the body trying to fight off the illness. But then it decreases over time, which causes the TSH to rise. And then as the free T4 comes back up, the TSH starts to normalize. So basically, what I'm trying to show by this graph is sometimes our abnormalities in our thyroid labs, whether low TSH with a high free T4, or you're getting a high TSH but with a normal or decreased free T4, you could, you know, if someone's had a recent illness or the thyroid labs were obtained in the time of an illness, often all bets are off in terms of interpreting those labs and making a clinical decision in terms of treatment. So that's definitely a situation where you're going to want to just repeat your labs, 6 to 8 weeks down the road and see how they're really trending. Okay, so here we have another case. This is an actual case that I saw. So a 9-year-old girl, she came to the emergency room. The family noticed that her eyes were really pink and both eyes got really bloodshot. She also was complaining of some cough and cold and feeling a little short of breath, so they felt like maybe she had pneumonia. When she gets to the emergency room, her heart rate is in the 170s. The family kind of mentions in passing that she's had 3 new prescriptions for her glasses for the year. They're not sure if she's lost weight. She has felt kind of hot. She's been having more loose stools, but no diarrhea. Seems kind of shaky, a little more anxious to family. And then kind of incidentally, at the very end of discussing all that, the family mentions in passing, oh, and it seems like she has this mass in her neck, but we haven't got to see a regular doctor yet for that. We're going to see them in a couple months. So this is what your patient looks like. At the time, the patient doesn't have a fever, but heart rate is elevated. Blood pressure is 137/80. They're tired, they're cachectic, they're anxious. They have exophthalmos with injected sclera. And in this case, that actually was what was causing all the redness. She actually she could only really close her eyelid about halfway down when she tried to close her eyes. On the thyroid gland, you can see it. I mean, it's just beautiful butterfly thyroid gland right across the room. You can see it poking out. It's very firm, which is very common for Graves' disease. Usually symmetric, usually non-tender, and usually you're not going to feel any nodules or lymphadenopathy either. She also was noted to have a systolic ejection murmur, but no pedal edema in her legs. So I don't know if you can see this slide, but at the bottom it says, we were just as surprised by the test results as you. We're still scratching our heads over it. Anyway, so what labs would you like? Anyone got an opinion on what labs they want to get?
I had TSH and free T4.
Okay.
Maybe a total T3.
Okay. All right. So yeah. So that would be a good panel, especially if you're concerned about hyperthyroidism. Very good. So in this case, the ED got a couple things, and it did show a TSH that was very suppressed, very high total T3, and a very high free T4. So these are kind of the labs that came back. They did get a CMP as well. Because of her tachycardia, someone ordered an EKG and they found it was sinus tachycardia. The TSH was very suppressed at 0.001. The free T4 was 5.6 with a normal reference range up to 1.4 on that lab. And total T3 was 738 with a normal to 185. Not available to you really in real time, but was available a couple days later, is that the thyroid stimulating immunoglobulin, or TSI, which is the test you'd send when you suspect Graves, was elevated at 353. Interesting too, those TPO and thyroglobulin antibodies were positive as well, and that's extremely common for Graves' disease, that you will have all 3 sets of positive antibodies. What's really happening is the TSI antibodies are predominating. And it's actually possible over the course of illness that Graves' disease can sometimes kind of wax and wane, even go into remission. And once in a while, those destructive antibodies will actually take the helm, and about 10% of patients with Graves' disease eventually actually developed acquired Hashimoto's and are hypothyroid. And then you can see the CBC there in the corner. That's not too remarkable. So this is kind of just a slide showing you what's happening with these, excuse me, these thyroid stimulating immunoglobulins. You can see kind of up here at the top, we've got coming over to the thyrotropin receptor. This is going to activate that receptor, make more thyroid hormone. Thyroid's going to release T4 and T3. T3 is going to be our most active hormone in the periphery. But T4 is also active. People often think of T3 as the only active thyroid hormone, but T4 is active in various tissues, including most notably the heart. So until you can get T4 levels in a normal range, a person will typically continue to have quite a bit of tachycardia, even if their total T3 has begun to normalize. And then over here, you can also see this is just kind of making a point about the proptosis. It's going to cause these fibroblasts to be activated. You get this T cell inflammatory cytokine, and then you get all these glycosaminoglycans that get into the muscle tissue, and you actually make anti-orbital muscle antibodies. And that causes the muscles to kind of cause the eyes to bulge forward. And you get that kind of frog eye appearance. So this is a nice slide that just kind of goes through all of the kind of symptoms that people have, of which she basically had all of them. She was very emotionally labile. She was very nervous. They did describe poor school performance over the last couple months after previously being an A student. She also had weakness in her muscles. She was complaining of palpitations, and often patients will. Although younger patients often struggle to explain what they're feeling. She had actually, even though family wasn't able to endorse weight loss, when we got a chart from her PCP, we found she'd actually lost 25 pounds. And you do usually get hyperdefecation. It's not actually usually diarrhea, it's usually frequency of bowel movements, and they may note that they're looser than usual, but they're not typically diarrhea. So when you ask that question, it's actually better to ask, how often are you stooling or pooping, and has it changed? Heat intolerance, very common. Interesting enough, she did have some rapid speech, and she had quite a bit of tremor when she put her arms out like this. She could not keep them straight. She definitely, if she kind of tried to look up and look down, there was a lid lag where her eyelids would come down, not in sync, but slower than usual. And then, like I said, her proptosis was so bad that she actually, her eyelid could only go about halfway down her eye, which is why her eyes were so red. And then it's certainly, if someone's moving towards thyroid storm, they're going to have some cardiac symptoms that could include a new murmur, widened pulse pressure, atrial fibrillation, pedal edema. This patient actually did go on to have several of those problems after they were admitted to the PICU. And then, again, your laboratory findings we kind of went through, but that suppressed TSH with those elevated levels should be a big red flag. So what would treatment be? Some of these things on the slide are really more for inpatient physicians than outpatient, but your mainstay, the thing that's going to provide the best help right from the beginning is a beta blocker. And that's actually going to provide the best symptomatic and otherwise relief. It also, to some degree, prevents conversion of T4 to T3 in the periphery, so you get less active thyroid hormone. And typically for a beta blocker in children, your best choice is going to be atenolol. It's more cardioselective. Kids seem to respond to it quite much better. There's been some teenagers that have been placed on other beta blockers in our region, and I often get phone calls about all kinds of problems that they've developed on those beta blockers. So atenolol is usually my go-to, and it seems to work very, very well. These other things on here are typically only used for thyroid storm. Steroids, for example, reduce T4 to T3 conversion, promotes vasomotor stability, and also could be used if you thought there could be some degree of adrenal insufficiency in the case for whatever reason. So this is kind of more of an adult thing that I found that kind of goes over some of these medicines. But just to kind of highlight at the top, adults do use PTU as well as methimazole. I kind of go into this a little more on the subsequent slide, but does anyone know why we don't use PTU in kids?
Pregnancy?
I'm sorry,
Pregnancy?
RDT. I couldn't quite hear you, sorry.
I thought it was related to pregnancy.
Oh, pregnancy. So in pregnancy, the first trimester, actually, methimazole is teratogenic. So in a teenage child who's being treated for Graves' disease, they'd actually come off their methimazole and go on to PTU. And then in the second and third trimester would typically be transitioned back to methimazole. But the main reason that PTU is not used is it has a much higher risk of liver failure and death related to that than methimazole. So PTU does have a black box warning, but except for it is used in our teenagers with Graves' disease in that first trimester. The boards love that question for whatever reason. And then you can use these iodide solutions. They're really great for someone who is seems to be very, very high, very, very symptomatic. It's only gonna last about a week or two before they'll escape from being given these kind of iodine containing solutions. But it does block release of stored thyroid hormone, which is part of the problem. Is there's so much stored thyroid hormone that can still be released that a lot of your interventions aren't gonna work too quick, including methimazole. Methimazole is really only going to really kind of start to make a big difference around week 4 to 6, which is why the beta blocker is going to be the mainstay to really help that person feel better until those levels are coming down. Something, again, that you could use more in a kind of severe hyperthyroidism or thyroid storm picture would be glucocorticoids. We often turn to hydrocortisone in children. It works really well. But dexamethasone would also be appropriate. And then beta blocker wise, again, we don't really use propranolol in children. We use atenolol, but we will use esmolol in a PICU setting if we needed it. So methimazole, the amount you give is really going to depend a lot on how symptomatic they are, how high their T3, T4 is. There's various articles that can kind of help you sort the dose, and we're always happy to help with methimazole dosing. Again, PTU is got that black box warning, and just as we talked about before, you're going to get the free T4, the total T3. So one time a total T3 is very, very helpful, and TSH, because that total T3 will be the first thing that gets better as you start treating with the atenolol and methimazole, and then your free T4 will typically start to get better. TSH recovery actually can take 4 to 6 months from initial start of treatment. So it's actually not too abnormal. Thing we're really looking for is for the free T4 and total T3 to get into the normal range. You're typically not going to want to take your patient off their atenolol until those levels are normal, including, as I mentioned before, the free T4, because T4 is cardioactive. I have noticed, and it's been a little bit of a problem for me, that I'll place a patient with Graves' disease on atenolol and start methimazole, and then they'll have a follow-up with their PCP, and the PCP will discontinue the atenolol. And then I'll usually get a call a couple days later that they've got really, really fast heart rates, and they're not feeling good, and they're having palpitations. So I would just recommend always contacting your endocrinologist if you're considering coming off atenolol, because that has actually happened frequently for us in this region. We do have people monitor their heart rates when they're on atenolol, and if patients don't know how to do that, they can get the monitor at Walmart, or we teach them how to do it, or both. But certainly what we basically try to tell families is if they're having any heart rates less than 60, they need to call us. And any heart rates greater than 120, they need to call us at rest, of course, not with activity. So we do teach families to do that, to kind of monitor it, and also let us know if they seem to be having any problems with dizziness or headaches or things like that. And then, like I said, it's going to take a while for that methimazole to work. So usually we're not going to get additional labs for another 4 weeks or so, unless we're really trying to trend to make sure that our methimazole dose is actually working. Sometimes if someone has really severe hyperthyroidism, I will get labs about 2 weeks into treatment just to make sure things are actually trending down. Excuse me. Any questions about methimazole or atenolol?
One quick question.
Yeah.
So you can still get a radioactive uptake scan even on methimazole?
Well, yeah, I guess you could, but I don't know why you would.
Well, when I was doing residency, the endocrinology there, I would work in the hospital. They'd always, I had like 2 hyperthyroid kids that came in very symptomatic, and they got admitted. And he was always pushing for, doing the radio uptake scan to sort of go between graves versus sort of a thyroiditis, sort of early Hashimoto's possibly, sort of help differentiate that.
Okay. Well, certainly early Hashimoto's can present, although usually not nearly this dramatic in any way. You're usually not going to get proptosis.
Well, yeah, if they don't have the eye thing, yeah.
Yeah, but people can initially be in a hyperthyroid state as initial thyroid stores are released in Hashimoto's disease, followed by a euthyroid state, followed by a hypothyroid state. What your physician was doing there is very old school,
Okay.
and people don't do that anymore. It's really just not even necessary now that we have all these antibody testings that can differentiate. If you're TSI positive and you have all these symptoms, you have Graves' disease. So really only in places where we get antibody negative people and nothing sorting out would we consider doing that kind of test with the radioactive iodine.
So it would be okay to start somebody on methimazole before we get the antibodies back?
Yes. Yeah, you can start methimazole before you get the antibodies back. And we commonly would, especially if the labs are very clear-cut. Okay. And atenolol, the same thing.
That's true.
You can always discontinue. And again, the methimazole is going to take quite a while to work. So you've got like 4 weeks to determine whether you want to keep the person on methimazole or not. And if you did come back with antibodies and it looked like they were actually having kind of a Hashimoto's related hyperthyroidism, you could always discontinue those medicines. And those people will typically be TSI negative and have TPO and thyroglobulin antibodies. You're not going to get all these dramatic changes from a Hashimoto's hyperthyroidism because it's a very short-lived, very kind of abrupt process. It can occasionally push someone into a thyroid storm picture. It's kind of rare. I've only seen it like twice. But so most of the time you're going to get, if you've got a case like this, you're going to have some really clear signs that hit to Graves. And again, also the thyroid's often very firm, where in Hashimoto's is more foggy and tends to be less, much smaller of a goiter. So, there's lots of things coming in terms of clinical judgment. Obviously, there's some cases that won't be as clear-cut, and we're always happy to help you with those or work through those with you. Once in a while, we won't know for sure ourselves. That's a really good question. Okay. Oops, why is it going backwards? Okay, I'm clicking the wrong thing. So one thing I just want to point out for methimazole, and I always go through this with my patients, but I like my primary care people to know too, is methimazole, even though it's obviously preferred quite a bit over PTU due to decreased hepatitis and liver failure and decreased vasculitis compared to PTU, it can cause those things, rarely. The minor things that we often see 5 to 10% of the time is you can get a little bit of a papular or urticarial rash. Sometimes people complain of a little bit of arthralgia. and some people will have a little bit of nausea or feel like they have an abnormal sense of taste. Of all those things I've seen, the most commonly is the skin rash. And then major concerns, which happen in 2 to 5% of patients, so up to 1 in 20, is agranulocytosis. So you can end up with a neutrophil count that's very, very low. I actually had someone who came in with an ANC of 0. And then very, very rarely, and I've never seen these other things, are the hepatitis, liver failure, and vasculitis. What you can see, though, not so much liver failure, but you can get transaminitis. And if you're getting it 2 to 3 times normal, then there's concern about continuing on the methimazole. So what we usually do in these kids is we will get a baseline CBC, so we know where they typically live in terms of their counts and their neutrophils and everything, as well as their LFTs. And then, you know, these complications are most likely to happen in the first 6 months of treatment. So that's where you're going to want to monitor for it, but they can happen at any time. So the things to know for a patient, if you have a patient in your office who has Graves on methimazole, is if they have a fever, you're kind of obligated to get a CBC, because if there's any suggestion that could be a bacterial infection, if they have agranulocytosis, they may not mount a response, and it could be deadly. So there's been reports of people who've had strep throat, for example, on methimazole, who've died, and they were just sent home by their PCPs with antibiotics. But they often had an ANC of 0. So they just didn't mount a proper response. So something is to always get a CBC if you think it could be a bacterial infection. Certainly, you know, if there's other signs or symptoms, you could get LFTs as well. But again, methimazole is our very best choice. It's the most effective. It's really the only truly effective medication, and ironically the safest for kids. Another thing, and I was kind of mentioning this earlier, is that Graves' remission rate, you got about a 25% remission rate in the first 2 years. Within 5 years, it's almost, or 4.5 to 5 years, it's about 50% remission. And then some get a permanent remission and then end up sometimes becoming hypothyroid from their TPO and thyroglobulin antibodies. And this chart actually kind of shows that a little bit right in there. That blue line kind of shows that 5-year mark with about half of people in remission. But the problem with that is that most people are going to recur. In fact, recurrence is very common, but the length of remission can be a month, it could be a year, it varies widely. So Graves' disease is a very unpredictable disease process that wax wanes, turns off, turns on, so you really have to watch it closely. In terms of second-line treatments for Graves, you could consider ablation with radioactive iodine. It's generally not used in children due to possible risk of increased risk for neoplasms in the future. So it's kind of a really unusual therapy in terms of children receiving radioactive iodine for this type of problem. Other treatments, and this has sometimes been, someone can have them on methimazole, try to keep titrating the dose. We kind of reach a level. If you're getting over 20 milligrams a day of methimazole, you're putting your patient at much higher risk of complications. So you have to be really careful not to create problems trying to fix a problem. So if someone's very unresponsive to methimazole, sometimes we will do surgery, and we have had a couple patients where that's been necessary. Sometimes it comes also down to patient preference. They just don't want to deal with the issue. Another thing is if they have a lot of proptosis. Proptosis is not good to use radioactive iodine on. It appears to actually increase complications in the eye. So even adults with a lot of proptosis should really hesitate to do radioactive iodine treatment. And then lastly, we're running out of time unfortunately, is this is just a nice slide to just kind of medications that your patients are on that can really kind of change things. Certainly Steroids, you can see that can cause TSH secretion to be decreased. You've got your amiodarone and your lithium is altering T4, T3 levels. If anyone's taking calcium or iron with their levothyroxine or soy milk, they're not going to absorb the thyroid hormone. And so you're going to make them hypothyroid. I have had probably 2 or 3 patients with congenital hypothyroidism in our region that were switched due to intolerance to their formula, to a soy formula, only to then develop again considerable hypothyroidism as a result, even though they were on treatment with levothyroxine. And then anticonvulsants would be the other really big offender that often alters T4 and T3 levels. And so when we have patients on those medications, it makes it that much harder to try to interpret what's going on. There's my family. Any questions?
In pediatric population, especially with type 1 diabetes, there's always, in teenagers, there's usually a increase of non-compliance. Have you noticed that with teenagers with especially hypothyroidism, with issues of compliance? And, you know, they get symptoms again, you're like, well, do we need to increase the dose, or are they taking it with the wrong medications in the morning or milk versus non-compliance? I mean, I think that in our world, that would be something you have to sort of do a lot of detective work. But do you notice a lot of issues with non-compliance as teenagers?
Absolutely. So, yeah, I mean, so it's interesting too, because sometimes I can see it in the labs, because sometimes kids will be like, oh, I'm going to the doctor this week. And so they'll suddenly start taking lots of thyroid hormone and maybe even start to take too much. So then I'll get a high TSH with a high free T4. And so I can see that they've tried to like take their medicine all at once. Sometimes we, like I said, if we do discover people are taking it with an iron supplement that's been prescribed to them, or calcium supplement, or soy. Those 3 things are big offenders and cause significant problems with thyroid hormone absorption. And then sometimes it just becomes really obvious over time, because the dosage of the medication and the weight of the child, and you go up on the medication, but then the TSH will keep rising. It starts to become pretty obvious when we're dealing with folks who aren't really taking their medicine. So I do quite a bit of motivational interviewing, trying to convince teenagers to take their medication regularly. Sometimes it's trying to convince them of the things that they really care about are going to be affected, which they often are. But like anything in adolescent medicine, compliance is a significant issue for us, even though you only have to take 1 little pill every morning. Any other questions? Kind of a whirlwind there. This lecture combines multiple cases from multiple lectures, so each one of those things we could have talked about for quite a bit longer.
No questions. Just want to say thank you so much for the talk and taking time out of your day to talk to us about this important subject.
Thank you for attending. I really appreciate everyone who came, and appreciate also those who had questions and participated too. Anyway, we're going to continue to do these echoes, and I can't remember when our next one is, but you should be getting an email on that. And we're hoping to do these also periodically so that we can keep reaching out to folks. And again, if you have questions, we're always happy to try to help. Sometimes the volume of questions exceeds our ability to answer them all timely. So be patient with us unless you have kind of a more urgent case. We're always try to jump on those as fast as we can. All right. Anything else for anybody? All right. Well, thanks for coming to the Echo, and hopefully you learned something new today that you can use in your practice.